Welcome, everybody. It's very exciting to have you here with us today on World Pre-eclampsia Day. And thank you for spending your precious time with us over the next couple of hours. We have some really interesting speakers, some really sort of thoughtful and new, exciting things to share with you. So I'm Andy Shannon. I'm professor here at King's College London, but I'm also chairman of A.Pec, and I just wanted to spend a couple of minutes telling you a little bit about A.Pec and maybe allude to some of the things that have been going on more recently in the pre-eclampsia world, with many which are very exciting. In the program today, we've been able to attract some really new speakers, or should say new research that is really going to be impactful. I'm delighted to be able to say that they're going to share stuff that's recently been published. A.Pec, I'm sure you realise, Action on Pre-eclampsia has a mission to look at the understanding, detection, care, education, awareness all around pre-eclampsia. And we ultimately want to improve outcomes for mothers and babies. Next slide, Abby, please. I think there are some very exciting areas now in the pre-eclampsia world. Things are evolving, to my mind, seems to have suddenly escalated in terms of change and improvements. I think the key thing about pre-eclampsia, it is not the commonest reason women die from in pregnancy, but it's perhaps the one that we can do something about the most, where there is most substandard care and where our actions can make a difference. And I think that's recognized as deaths from hemorrhage are being tackled. This is the one area where we really should be and can do something worthwhile and different. There have been huge advances, a huge literature now on screening, and this isn't just screening first trimester, but across all gestations, and the importance of targeting management right the way from first trimester through to third trimester is crucial. I think we now realize that pre-eclampsia causes can happen at any gestation, at any time, and management across the spectrum is critical. Prophylaxis, for example, aspirin has a very important role to play, but it tends to target early pre-eclampsia. And we now know, of course, the focus on term pre-eclampsia is exceptionally important, where targeting and management later is also a massive lifesaver. New data coming out on calcium suggesting it's not the panacea that we thought it was, and the refocus on aspirin is pretty important. There's new evidence around managing hypertension, what agents to use, sort of nuance around how we give magnesium sulfate. The WHO are looking at different ways of, comparing routes of administration. And excitingly today, or just last couple of days, we have a new meta-analysis that's come out on the timing of delivery, which we're able to share with you today. I think that's really key, because delivering the woman is at the moment the key way to improve outcomes, actually save lives. A lot of the management prior to that is really just keeping safe until you can do that definitive management of delivery. And I think how we identify those who need to be delivered and the details around that are obviously a really important focus for the future. Very excitingly, there are people looking at fundamental therapeutic interventions that will potentially cure pre-eclampsia, which we don't have yet. There's a big focus looking at suppressing S-FLIT. This may be a very exciting intervention for the future. There are other people also looking at drugs and agents that might improve outcomes. So this is a space to watch. But in the meantime, there's no doubt that better management can make a huge difference to outcomes. And there is every evidence we just aren't anywhere near that yet. So a lot of what we're going to focus on today is looking at that. Next slide, please, Abby. So just quickly, I just wanted to acknowledge Chris Redman, who unfortunately died recently. He really was the grandfather of pre-eclampsia. I think many of us knew him and know him, and it was really him that started up APEC back in 1992. And I'm delighted to say that APEC now is rapidly expanding into an international entity with many supporters. APEC is not us, it is you. It's anyone who is involved with managing and helping spread the word about preeclampsia is part of APEC, and we really would like you to be an advocate for us. And just to acknowledge Isabel Walker and Joyce Cohen, who were also fundamental to that original startup. Next slide. We in APEC do a lot of things, and perhaps engaging in research is one of the most important. We've been involved with about 60 different papers as a patient public involvement credibility from the charity, as long as many other initiatives. And there are other really great societies around the world in preeclampsia. So we work with them, and the APEC brand, as it were, has had some phenomenal success. Zambia's recently started up, South Africa's starting up, Ghana, Australia, and so on are particular examples of excellence making a difference. And we would really like anybody to engage, and we can help with web resources and so on and so forth. Next slide. So there's a lot we do. There's a lot of online stuff which you have access to. It is all free. We arrange study days. We're increasingly doing international work, and we have a helpline. Next slide, Abby. Just in the context of our high income setting, we have a lot of people contacting us. Here are the themes of what people ask. And I think we provide a really great function. We learn a lot from the women. And one of the things we really should do when we're thinking about all the interventions is actually, what do women want? What is there a need for? And there's no doubt that we could be doing this better. Next slide. Just to let you know, there are online free courses available. And if you are an educationalist and you would like access to these and use them in your training systems with recognition, we would be more than delighted to help. And please, do get in contact if you would like to make use of these. As far as we're concerned, the more people who access these, the more that use them, the better. Next slide. I think research is key, and a lot of what we'll talk today about is research. This is how we move forward. And this is something where PPIE involvement is really critical, what people want. Okay, next slide. So just some examples of some of the studies that we have been involved with recently. And if you are going to do research and you would like some functional involvement from PPIE perspective, please do ask us. We have contacts with all the right people who could help that. And I think that's a really important part of what the charity does. Next slide. So please be an advocate. I think APEC is all of us. It's not just the charity or people who work in it. We would love you to be an advocate for APEC, promote it, set up your own entity, and obviously support fundraising for yourselves in what you do. Next slide. So we will talk a little bit later about some practical things that we should all perhaps get involved with to make a difference. We are going to talk about APEC International, but there is a lot of resources on this website, from textbooks to guidelines, and we would like this to evolve so that it becomes a bespoke entity for any country who wants to use it. Next slide. Please do put in your sort of save the date. November the 19th, we'll have a full day, what we call an expert day, which has been incredibly successful and popular over the last few years. It'll be an online resource. So do kind of keep that day free, and we'd be very interested in hearing from you if you would like to contribute to that day. So just to say thank you, there's Abby on the left who's helping us today. Debbie, the two of them are phenomenally busy and really drive the success of the charity. And I'm deliberately going to finish with a video that's been put together by some of our teams, not coming from us, but really coming from women and what preeclampsia means to me, to them, and therefore it gives us a focus on why we're all at this meeting today. So Abby, if you can share that video, that would be great.
This World Pre-eclampsia Day, we asked survivors of preeclampsia, if you could send one message to healthcare and research professionals, what would you say? I want to know if my life will be the same after suffering from preeclampsia. I want to know if I can ever have a preeclampsia-free pregnancy after surviving preeclampsia twice. I want more sensitization on preeclampsia. I want the cradle blood pressure machine in the community for screening. Preeclampsia awareness is a need for every pregnant and postpartum woman. I want free medication, not prescriptions all the time. I want a cradle blood pressure machine in my community and to train people to use it. Medical professionals in the community should embark on sensitization. We want awareness, early detection, support groups and counselling for every mother and baby to survive preeclampsia and go home together.
Thank you to the team there who put that together. And I think it's a really nice focus to say, what do women want? And I think that engagement and communication is something we're not always good at. As academics, we concentrate on the interventions and the science, but there has to be a whole spectrum of activities to make a difference. And one of the key things about preeclampsia is not just to know what to do, but to get that care to the people who need it, and most importantly, get them to accept that care or to want that care and to spread it. So I think this is, the whole spectrum is how we're going to make a difference in this disease. So I'm delighted to be able to, first of all, we've attracted some fantastic speakers, and there is some new evidence, and I think it's very exciting to be able to share this with you. When I first saw this, I was blown away, and I'm delighted that this has now been published in a very nice publication in PLOS Medicine, which is a fairly high impact journal, come out in the last few weeks. Lena Bergman has a phenomenal opportunity to really answer some important questions in this disease, living between South Africa and Sweden, having a very astute scientific mind and clinical expertise, and supported by a phenomenal epidemiologist, Roxanne Hastie, who did her PhD back in 2018. And I think this team working and the sort of geography that the team works in has really produced some novel and exciting new work that I think we can all learn from. And I'm absolutely delighted that they've got time to come and share with us some of their findings. I think this is something new, different, and it should be something we should be using. So Lena, thank you so much. I'll let you kick off. And Roxanne, thank you for spending your time with us.
Thank you so much, Andy, and we are so grateful to be invited to this important seminar on this very important day, our most important day of the year, the Preeclampsia Awareness Day, to present these findings. And it's Roxanne Hastie who will be doing most of the presentation today, who has led this multinational study of novel symptoms for eclampsia. I will give you a brief background to the area and why this is needed and important, and then Roxanne will present our hopefully exciting findings that can be useful for all of us. So this is a collaboration between several different countries. Roxanne leads this study from Australia, Melbourne University and Mercy Perinatal. And the study has been conducted in 2 countries, South Africa and Pakistan, that Roxanne will tell you more about later. But for the background, so eclampsia is actually the origin of the whole disease. It's expressed by like a flash of lightning in Greek, and it was discovered already about 400 years ago, where pregnant women suddenly fitted. Then we started to think about why was this happening, and we discovered the pre-stage to eclampsia, which was called then pre-eclampsia. But from the beginning, it was actually eclampsia was the phenotype of the disease. And eclampsia is a serious condition. It's one of the most common causes of maternal mortality and morbidity connected to pre-eclampsia, and one of the most feared complications worldwide. In low and middle income countries, it's seen quite often, like in South Africa where I work, we see at least one woman a week, whereas at my equally sized site in Sweden, we almost never see eclampsia. So it's very varying across the world. And eclampsia can also give other complications like intracerebral bleeding, which has a high association to maternal mortality. Women with eclampsia often suffers from cerebral edema, up to 80% of cases. If the cerebral edema progresses and gets worse, it can result in herniation of the brain, which is also connected to a high risk of mortality. Women can also experience blindness in the acute phase. Previously, eclampsia thought to be reversible, but over the last years, it has been shown that women with previous preeclampsia, and in particular eclampsia, also are at risk for longer-term complications, such as cognitive dysfunction, where these women complain about handling life skills worse, like they forget what they were supposed to do, moving from one room to another, for example, at a higher degree. They also more often suffer from migraine, new onset migraine after pregnancy, and new onset epilepsy the years after preeclampsia and eclampsia. We've also shown that these women are more often on sick leave. And this is often non-explained, so these women often fall in between and they don't really feel like they get the support they need. On the longer term, women with previous preeclampsia also are at higher risk for vascular dementia, and some studies also show that these women are at increased risk of Alzheimer's disease. So, and also more well-known since previous, women with previous preeclampsia are at about 3 times increased risk of stroke later in life. So can we prevent this condition? Well, we don't have many medications in pregnancy, and that's a problem in itself. Like Andy said in the beginning, there are exciting new development of medications in this space. For eclampsia, we actually have had a management and a medication since long way back. The use of magnesium sulfate has shown to prevent eclampsia with about a protective effect of 60%. So it's a really good medication if you can target the right number of women. And this Cochrane overview show that you need to treat about 60 women with severe preeclampsia to avoid 1 case of eclampsia, if eclampsia is as common as 3%. And the numbers needed to treat for all preeclampsia is 118. It might not seem so much, but magnesium sulfate is a treatment that needs to be provided under surveillance. So these women need to be checked for the urinary output, their reflexes, their breathing, their respiratory rate, and you have to have an antidote present. So it would be favorable if we could target this group better. In addition to this, if we go to the next slide, most women who suffer from eclampsia have not been detected before fitting. So this study is from Finland, and in this study, it was only 7% of women that had eclampsia who had the opportunity to receive magnesium sulfate before seizures. So it's really difficult for us to target women who are at risk of eclampsia, and the current symptoms and signs that we use are not working really well. So if we move to the next slide, we've shown in a systematic review, this is now about 7 years old, we looked for how do our symptoms actually perform. We did a systematic review, it was Roxanne Hasty who led that as well. And when we looked at these symptoms that we all as clinicians and hopefully as patients recognize, and women are told to look out for these symptoms, you can see the numbers here for sensitivity and specificity are pretty low for both visual disturbances, epigastric pain, and headache. And this means like the sensitivity that we don't catch all women who actually will develop seizures, and the specificity means that we will actually say that women are at risk who are not at risk. So we will unnecessarily treat some women, and we will not detect the majority of women who will later develop eclampsia. We then redid the systematic review because we thought surely things have happened over 5-6 years. And this is our joint PhD student Valentina, who's listening in today, who led this work. And unfortunately, there were still no promising predictors out there when we pooled data from 15 different studies with 37 predictive tests. So that led us to our research question, if we could find better signs and symptoms for eclampsia. So I leave it over to Roxanne to present the eye study and the findings from that study.
Thanks so much, Lena. I think that was a great introduction to the rest of the study. And as Lena said, our previous work really highlighted that their existing symptoms that are currently used weren't great at predicting women who are at risk and identifying those who would benefit from magnesium sulfate. And it was this that led us to the eye study, or the improved characterization of eclampsia study, with the whole aim of trying to develop or identify existing signs or symptoms that might be able to better predict women who are at risk of eclampsia, so that we can allow for the timely administration of magnesium sulfate and ultimately reduce the risk of this life-threatening complication. And so given eclampsia is an acute neurological complication among women with pre-eclampsia, we wondered whether there might be symptoms or neurological symptoms that are used outside of pregnancy that might be able to better predict or identify those who are at risk. And we had a fantastic team pulled together to answer this question, but none of us were neurologists. And so we looked for an academic neurologist, and we found one. His name was Professor Bernard Yan, who's a neurologist at Melbourne University. And we said to Bernard, outside of pregnancy and eclampsia, what are the signs and symptoms that are being commonly used that we could potentially ask women about and see if they apply in this setting? And so, working with our team, and Bernard included, we developed a survey that would be asked of women with pre-eclampsia and eclampsia to just see if there were some symptoms that stood out better than what we're currently using. We, of course, included the symptoms that are currently used, so edema, headache, visual disturbances, epigastric pain, and then also looked at tightness of chest, tightness in the chest, shortness of breath, focal neurological deficits, including where in the body these are occurring. We also looked at nausea and vomiting, whether or not women with eclampsia suffered from confusion, or they experienced twitching or jerking of their arms or legs, whether they experienced difficulty concentrating, whether their speech was affected or their hearing, any changes in mood, whether they felt anxious, whether they felt an impending sense of doom or that the world was ending prior to their seizure onset, whether they experienced severe dizziness, weakness, paralysis, or jitters, and nervousness and shaking. And so this was really the survey that formed the basis of our study. And so we recruited women who had experienced eclampsia, and within our study, they had to have experienced eclampsia within the last 7 days. So once they were well and able enough to answer the survey, they were approached by our research team to complete the questionnaire. And again, this had to be within the last 7 days. We also asked women who experienced pre-eclampsia but without eclampsia the exact same symptoms and signs. So everyone received the same questionnaire. We just had to say prior to recruitment rather than prior to your eclamptic episode. We also included women who were normotensive, because we know that there are some women who develop eclampsia that are normotensive prior to their seizure onset. But just for the brevity of the talk today, I'll be focusing largely on our analysis between pre-eclampsia and eclampsia. And so this was a multinational case cohort study that recruited women from South Africa and Pakistan. And this was really only possible because of our fantastic team, including Professor Kathy Kluver from Stellenbosch University and Tigerberg Hospital, and Professor Farhat Ahmed who's from Lahore in Pakistan at Fatima Memorial Hospital. And so working with them and their teams, we're able to recruit women across both countries. And again, this study would not have been possible without their fantastic leadership at each site. And so there were 3 sites. We had 2 in Pakistan and then 1 in Cape Town. We recruited 2,142 women. We subsequently had to exclude 57 of them. 23 in the pre-eclampsia cohort actually developed eclampsia after the seizure onset. So they were excluded from our primary analysis. 3 women who were normotensive later developed hypertension. 19 women who were normotensive later developed pre-eclampsia, and 12 women from our eclamptic seizure group actually had their fit with more than 7 days. So they were also excluded. And so across these women, 341 women had experienced eclampsia and were included in our study, 1,355 with pre-eclampsia, and 389 women who were normotensive. And again, largely going to be focusing on that eclampsia and pre-eclampsia group here. And so first, looking at the symptoms that we would often be used clinically, so headache, visual disturbances, and epigastric pain. We saw that for women with eclampsia, 88% reported experiencing a headache prior to their seizure, whereas 74% of women with pre-eclampsia experienced headache. So quite common in both groups, and this resulted in an odds ratio of 2.56. Looking at visual disturbances, 65% of women in the eclamptic group reported experiencing visual disturbances, compared with 24.6% in the pre-eclampsia group, so a slightly higher odds ratio of just under 6 there. And for women with epigastric pain, 41% in the eclamptic group experienced this, compared with 24% in the pre-eclamptic group, and an odds ratio of 2.25. So just over a twofold increase in the association between epigastric pain and eclampsia. And we saw that these findings were largely similar to what had been previously reported from our systematic reviews as well. But what was really exciting was that we'd identified 10 symptoms that were far more strongly associated with eclampsia than what is currently used. And so I will just go through those 10 now. So the first was whether they experienced weakness or paralysis. So 20% of women in the eclamptic group reported experiencing this prior to their seizure, compared with just 2.4% of women with preeclampsia. And this was a 10-fold increase in the likelihood of experiencing eclampsia with weakness and paralysis compared with preeclampsia. Reporting difficulty concentrating, just under 60% of women experienced this in the eclamptic group, compared with just 7.8% in the pre-eclamptic group, and this was a 15-fold increase in the likelihood. We looked at jitters or nervous shaking. 20% of women in the eclamptic group experienced this, compared with just 1.4% in the pre-eclampsia group, so just under a 20-fold increase in the likelihood there. For confusion, 40% of women said that they felt confused prior to their seizure onset, compared with 3% in the pre-eclamptic group, and a 20-fold increase in the likelihood. The feeling of impending doom, or as though the world was ending, this occurred in just under half of women with eclampsia, compared with just 3% of women with pre-eclampsia, and this was a 23-fold increase in the likelihood of experiencing this with eclampsia. For severe vertigo, 5.6% of women experienced this who had eclampsia, compared with 0.2% in the pre-eclamptic group, and an odds ratio of 26.59. Reporting that their speech was affected, this was just under 30% of women with eclampsia, compared with 1.2% of women in the pre-eclamptic group, and so an odds ratio of 33. For reporting that their mind state had been affected, and this was 38.7% in the eclamptic group, compared with 1.8% with pre-eclampsia, and a likelihood of 33-fold increase in the likelihood. Hearing affected, so 20% of women experienced that their hearing was affected before their seizure, compared with just 0.7% in the pre-eclamptic group, and 36-fold increase in the likelihood. And lastly, for twitching or jerking of arms or legs, 30% of women who experienced eclampsia said that they had this before their seizure, compared with just 1% in the pre-eclamptic group, resulting in an odds ratio of 42. So these symptoms look like they are far more strongly associated with eclampsia compared to what's being currently used, and may have potential to be able to alert us to those who might benefit best from magnesium sulfate. We also split our analysis by country just to see how it's performing across the two countries. And you can see for our known symptoms, headache, visual disturbances, and epigastric pain, they're very similar between Pakistan and South Africa. And again, 10 novel symptoms were again quite similar between the two sites, with a little bit of difference, which I think would be expected between two different countries. Just briefly, as I said, we did also look at eclampsia versus normotensive women, so I'll just very briefly walk you through that. But for those known symptoms, you can see that they're quite infrequently occurring for our normotensive patients, which I guess would be expected, but 3% experienced headache, and this resulted in very high odds ratios because of those low numbers in our control group. But for our novel symptoms, you can see that these were very rare, occurring infrequently, mostly 0 in our normotensive women. We also looked at the number of symptoms that had been experienced across the cohort. And so across the 20 symptoms that we looked at in total, only 2.4% of women with eclampsia experienced none of these. So 97% of women with eclampsia experienced one or more of the 20 symptoms that we looked at. We then looked at the 10 novel symptoms, but also included the 3 pre-existing, so headache, visual disturbances, and epigastric pain, so 13 in total, and just looked at the number experienced across these 13 symptoms. And we saw that just 6.1% of women who experience eclampsia experienced none of these symptoms, compared with 20% in the pre-eclamptic group, and reassuringly, 95% of women in the normotensive group did not experience any of these. And if we look at women who experience more than 2 symptoms, 87% of women who experienced eclampsia experienced 2 or more of these 13 symptoms. So they're quite common amongst women with eclampsia. And so in conclusion, our study identified 10 new or underutilized symptoms that may be able to alert clinicians to women at risk of eclampsia, including twitching and jerking of their arms or legs, having their hearing affected, an altered mind state, speech affected, severe vertigo, feelings of impending doom, confusion, jitters or nervous shaking, and difficulty concentrating. Only 2.4% of women with eclampsia experienced no symptoms, and these were less common for women with pre-eclampsia. And future studies are really needed to validate these findings and really start to consider the timing of onset. It's great that we've identified these novel symptoms, but now we need to understand whether or not they occur with enough time for magnesium sulfate to be administered and to be effective. And lastly, and very importantly, I need to say a very big thank you to our multinational team, especially to Kathy and Lena and Farhat, who really led a lot of these works on the ground in Cape Town and Pakistan. And also, really importantly, a big thank you to all the women that participated in this study, including the 341 women who experienced this very severe complication, and we're still happy to be involved in the work. And thank you so much for the opportunity to share this with you all. And I will stop sharing.
Roxanne, thank you. That was very clear. And I just want to congratulate you both again and all your teams for coming up with something, in an area where disease is so common, we've known about it for so long, and suddenly to come up with something that is meaningful and new is very exciting. And I think it's a reflection on, going into these challenging environments where these problems are common and doing research where it matters. So I think that's a real lesson for all of us in terms of how do we make a difference now. Can I just say, if people have, there's a Q&A box, so please do put your questions in. We've got a few minutes that we can make use of our colleagues here's knowledge. I'm just going to kick off by one or two things that have been asked. So, I will declare that I'm gobsmacked and very impressed by what you've done, and we wrote an editorial about this. But I will ask you some of the obvious questions. So, given the findings being so obvious, there is obviously a retrospective nature to the detection. And the big question is this good enough to do something now? Or should we be doing something more before putting this into guidelines? I have a view on this, but I just wanted to know what you're going to tell people.
Look,
Roxanne,
I'm a big fan of validation. And there is, of course, the retrospective nature of this study. But I would say prospectively recruiting 340 women with eclampsia is a pretty hard task. And so overcoming that will be quite difficult. We'd love to hear how that could be overcome and next steps and validation. would be
And
great.
yeah, just to add, there is a small subset in this publication where women actually were enrolled with
Mm.
preeclampsia, and then they did develop eclampsia, about 20 or so plus women, I think, in that group,
23.
Roxanne. Yeah. And in that group, many of these novel symptoms are still standing out. And I think one of the weaknesses with the study is that we didn't really ask them about the timeline. We asked about the timeline for the established symptoms, but not for the new symptoms. So, of course, they need to be occurring, not just 1 second before the fit. And that is something important to figure out, I think. But at the same time, when we move back to the systematic reviews, most of that evidence comes from case control studies if you experience visual disturbances or headaches. So, if I can put it like this, we don't have better evidence for the symptoms that we currently ask for compared to these new symptoms. But then, of course, it would be great to, in parallel, validate these and see timeline-wise if they occur, early enough, and with this recall bias if they are, as strong in a prospective cohort. So maybe both.
Great, that's great. I mean, the obvious questions coming through there is, what do we do? How do we actually put these into clinical practice? Is it just a sort of interesting nuance, or could we actually use this knowledge to change management now? Do you have a view on that?
As an obstetrician, when I'm in the ward and try to assess whether this woman is eligible for magnesium sulfate, at least I know that if she's now experienced jitteriness, nervousness, shaking, she has a hearing deficit, I would be much more inclined to be worried than if she would only have headache. So I think with this knowledge, we can still improve care for women. But I think in parallel, if we also can prospectively validate this in settings that matters. I know that you have plans, for example, in Sierra Leone, and if we get enough outcomes and we can show this temporal trend that this is actually useful, hours before the fit or when it's time for magnesium sulfate, I think we can do both. But me as an obstetrician, I am already thinking a bit differently after discovering these symptoms.
And if you look at the specificity, it's 80, 98, 99 for a lot of them, which we didn't report in the paper, but it's a good rule in test. I wouldn't say it's good rule out, but if we're talking rule in, you might be willing to act on this if you're having some of these symptoms.
Sorry,
I think you
Andy,
might be
you're on
muted.
mute.
So just another question about country differences. I think you alluded to some differences across the globe, as it were. Are you kind of challenging everyone here to start looking in their own environments, or is eclampsia a generic disease? How do you account for that?
It's a good question. It would be interesting to see how it performs more broadly across different settings. It's always important to ensure that this is holding up in different settings. But if we're seeing that headache, visual disturbances, and epigastric pain are being used across the board and do perform relatively stable, you'd hopefully think that this would be the same.
And I think what we already have a strong case having two countries in complete different settings, Pakistan and South Africa, and they, as you could see in Roxanne's box plots, or forest plots, they performed quite similar regarding almost all these symptoms, which was a strong signal, I think.
Yeah. Okay. There's another question, which is a slightly more generalized question that I think we all care about, which is the sort of disproportional representation, what they say, of Black and brown women in the pre-eclampsia maternal death world. You obviously have a very, well, not quite unique, but interesting perspective of working across these different environments. Is there a view about why these discrepancies are they related to care, related to other things? And I guess the question here is, what are we going to do about it?
I mean, this is a personal view in combination with what evidence has shown from my part, and I think it's a question of care and how we detect and treat. And as you can see in this very different populations, Asian versus mostly Black South African women, the symptoms are very similar. We do a lot of parallel studies between Sweden and South Africa as well, and we see there that, signs and symptoms and biomarkers seem to be pretty similar. And it seems the highest risk factors seems to be like not attending antenatal care, for example, for eclampsia, teenage pregnancies, socio-demographic factors like that. And of course, as we see in the US, some racism in healthcare, maternal care deserts. So I think that's the overall, the biggest impact as I can see it.
Yes. Yeah. I mean, couldn't agree more, Lena. I mean, the inequalities in this disease are just staggering and reversible as far as I can see. There
Definitely
are
so.
things we can do now, all of us, that will make a big difference tomorrow, as opposed to, fundamental, long grind. So yeah, I sort of agree with that. We had one of our panelists who can't get into the Q&A wanted to ask a question. Chaleshi, are you still there, and can you unmute?
I am still here, but you preempted my question, of course. No, it was about, that profound, it's such a profound experience, I think, to have a fit in pregnancy. And so obviously I think that issue of confirmation bias, but it was very, very robustly discussed. I was happy with the response.
Thank you.
Okay, thanks, Shashi. Well, look, we just incredibly grateful and very excited by your paper. I think it's really impactful. I think one of the things we said in the editorial was, isn't it nice to have something simple, worthwhile, and makes a difference without having to, use AI or fancy equipment and all the rest of it. And I think it's a real lesson that sometimes the most impactful things are under our nose, and we just need to go looking. So I think a real lesson for all of us. So Lena, thank you for your time, and Roxanne, thank you. And what a dynamite team. I think it's another lesson that this, having the sort of multiple professional backgrounds when addressing these questions, going to the neurologists, keeping your eyes open. That's how we make a difference. Going to the new populations, going to the new knowledge, using people's expertise. I think it's all very exciting. Enjoy the rest of your World Pre-eclampsia Day, and do stay with us if you would like to. Thank you so much.
Thank you.
Thank you. Thank you so much for the invite.
Okay, brilliant. We're going to move on now. I think one of the big areas that we clearly are learning more and more about is the opportunity to use pregnancy as a sort of window of identifying longer term risk. And there is an exploding sort of evidence base around how preeclampsia now is a sort of window again to talk about women having long-term cardiovascular events. And the big question is, what do we do about that? How do we make use of that knowledge to improve long-term outcomes? I'm really delighted to be able to introduce Anismus. I'm not going to try your surname, but another person who is an obstetrician gynecologist from Uganda, clearly has some academic credentials in terms of getting involved in research in a really important part of the world. I believe is starting or doing now a PhD, Cambridge, looking at genetics and renal disease. Again, a really interesting area, a new and exciting contribution to our knowledge in the preeclampsia world. And you're going to tell us a little bit about cardiovascular risk. Is that right?
Yes.
Great. Yeah.
Thank you very much.
You take pole position here. Yeah, going to listen on the computer.
Thank you very much. My name is Onesimus Yamukama. I'm an obstetrician gynecologist from Uganda. I've done my medical practice for the last 8 years in Uganda. Currently, I'm pursuing a PhD in medicine at the University of Cambridge. And my interest is in preeclampsia, long-term renal risk, and genetic polymorphisms. Today, I'll be sharing with you the long-term cardiorenal health after preeclampsia beyond delivery. Thank you. Next. Yeah, so we know that delivery ends the pregnancy, but this does not end care of the woman who has suffered from preeclampsia. And as part of the introduction, preeclampsia we know affects about 10% of all pregnancies, and this accounts for about 16 to 22% of all maternal deaths. And the burden and mortality from this condition are disproportionately high in sub-Saharan Africa. And we also know that it is most often treated as an acute obstetric emergency, but let's be mindful that it's an early marker of future cardiorenal disease risk. And the postpartum period gives us a very critical window through which we can do most of the prevention strategies. Next. It's very significant because it remains a major contributor to maternal and perinatal morbidity and mortality globally. And some of the long-term risks that have been identified from different studies include chronic hypertension, heart failure, stroke, chronic kidney disease, and end-stage kidney disease. And in sub-Saharan Africa and most of the low middle income countries, postpartum follow-up is often poor and very inconsistent. From one of the systematic reviews and meta-analysis that I looked at, some of the cardiovascular events like heart failure, chronic hypertension, you have preeclampsia actually carrying a risk of up to 4 times compared to the normotensives. But also other cardiovascular events like stroke and coronary heart diseases that carry almost a double risk. And the key message here is that preeclampsia is not over at delivery. The risk still persists. We also have evidence from large cohort studies, and one of these recruited women prospectively, and about 220,000 women were recruited, but about 1.3% of them had hypertensive disorders of pregnancy. And it was looking at long-term cardiovascular risk in women with hypertension during pregnancy. And some of their findings were still coronary artery diseases, heart failure, aortic stenosis, and mitral regurgitation. And so hypertension surely increases the high rates of cardiovascular diseases later in pregnancy, as you would see. Next. But who is at risk? So yes, preeclampsia carries the risk, but not all preeclampsia carries the same future risk. So there is an increased risk with any prior condition of preeclampsia, but then the risk is higher in those that have early onset preeclampsia, those that have severe features of preeclampsia, and those with preeclampsia with fetal growth restriction. But the women that carry the highest risk are those that have a recurrent episode of preeclampsia, persistent postpartum hypertension or renal dysfunction, and then preeclampsia with either chronic hypertension, diabetes, obesity, or a strong family history. And the risk increases as you go down the strata. Next. Preeclampsia is also associated with later kidney disease and some of the kidney conditions that we can look at: albuminuria or persistent proteinuria, reduced EGFR, chronic kidney disease, end-stage kidney disease, and the risk is about 2 to 6.5 in some of the conditions. The key message here is that renal risk persists after delivery as well, and albuminuria may be present even when the creatinine appears normal actually. And it should be of a higher concern in case one has early onset preeclampsia, or if they have preeclampsia with acute kidney injury presentation, and the other cases like severe preeclampsia or a recurrent episode of preeclampsia. And follow-up should really include things like blood pressure measurement and monitoring, urine ACR or proteinuria, serum creatinine, and the calculation of the EGFR. Next. So the mechanism of injury, I will not go through all this, but we know that with abnormal placentation, you have placental ischemia and an imbalance in the angiogenic pathways, which will later lead to inflammation, oxidative stress that will cause endothelial damage, and that's the hallmark of preeclampsia. But at the kidney, there is renal, microvascular and glomerular injury. So you have glomerular endotheliosis, you have podocyte injury, you have reduced renal perfusion, and tubular injury, which will give you acute kidney injury. And we also need to remember that preeclampsia and other hypertensive disorders of pregnancy may actually unmask and diagnose renal disease that might present later in life. Next. So there is a postpartum gap, and it exists. Many times after delivery, women are discharged once the acute episode is controlled, and once the blood pressures are controlled, and a lot of time the postpartum care focuses on the baby, focuses on contraception, on wound care, and the immediate complication. The longer term risk counseling that includes renal cardiovascular risks, rarely done, but as well as blood pressure monitoring, renal surveillance, a lot of times they are inconsistent and even absent. As a result, the woman that is at high risk becomes actually invisible to the healthcare system. And we should remember that a missed follow-up is actually a missed prevention opportunity. Next. So the burden and the evidence gap really exists. The cardiorenal sequelae after preeclampsia is global, but the recognition and long-term surveillance are very uneven. In high-income countries in North America, Europe, there is better recognition and more published long-term data, but then still the postpartum follow-up remains inconsistent. In most of the middle-income countries in Asia and South America, there are some substantial studies and quantification of the burden, but then still the follow-up is not standardized. In sub-Saharan Africa, which carries the highest burden of hypertensive disorders of pregnancy, we do have limited long-term cardiorenal follow-up data. And there's also restricted access to renal testing, specialist care, as well as some interventions like dialysis. Next. So a practical postpartum follow-up pathway would include counseling at discharge, documentation of the episode of preeclampsia, and a plan for a blood pressure review. Within 1 week, it's key that we have a blood pressure check for the woman, review the medication, review the danger signs, and within 6 to 8 weeks, as they come back for immunization, have a blood pressure check, ACRO protein check, creatinine, and estimation of the eGFR. And 3 to 6 months, we should be able to repeat some of the investigations if they are abnormal and reclassify the risk. And then the woman who has suffered preeclampsia should have a long-term annual BP check and a cardiovascular risk assessment. And if there are any abnormalities, then they need to be referred to the appropriate person. And if it's a renal abnormality, then a nephrologist would be very key. The core principle is that postpartum care should be an ongoing process and should not be a one-time isolated visit. And it's key that we adapt pathways to the local resources, so taking advantage of the primary healthcare systems, the maternal child healthcare clinics, community healthcare workers, and referral systems can be very helpful in us conducting the surveillance of the women. What should the health care practitioners do after discharge? Control the blood pressure. So it's key that we monitor the blood pressure and ensure that it's controlled, review the medication, screen for proteinuria, counsel the woman on lifestyle and future cardiovascular and cardiorenal risk, screen for diabetes and dyslipidemias, and then plan for the future pregnancies. So postpartum family planning, but also preconception counseling. And then in the future pregnancy, it's key that we do give aspirin prophylaxis. Next. Special considerations for sub-Saharan Africa. We already know that the highest burden of disease, and especially the severe disease in sub-Saharan Africa, and a lot of times there is late presentation to the healthcare settings. And as well, we have limited access to the renal testing and the cardiac testing, as well as specialist referrals. And the postpartum follow-up systems are often poor and fragmented. And we need to integrate the screening, cardiovascular and cardiorenal risk surveillance into the maternal and child health clinics, the non-communicable disease clinics, and community platforms for us to be able to follow up with these women. There's also need for us to generate data from sub-Saharan Africa, longitudinal data that will be able to inform us of the different sequelae that we have. And the key message here is that simple, feasible, and integrated follow-up models may actually have a very great impact in such settings. So in conclusion, preeclampsia is a mark of future cardiovascular and renal risk, and severe preeclampsia, early onset preeclampsia, recurrent disease, preterm disease may warrant particular attention, and postpartum BP and kidney assessment should become routine after preeclampsia, not a one-time measurement. And the postpartum period is a prevention window and not just a recovery period. And I'll end with this message that every woman who survives preeclampsia deserves a pathway for a lifelong cardiovascular and kidney health. Thank you very much.
Thank you so much, Onesmus. That was, I learned a lot in the last 10 minutes, and I think actually there's a lot of people in this room that I know completely can relate with the importance of kind of postnatal follow-up and ongoing management of these really high-risk women. And it's definitely something that we shouldn't ignore and forget about once the baby has been delivered. I think we have someone who's raised their hand. I don't know if you can. Oh, I can allow you to speak. Okay, Dr. Mbarara, do you want to ask your question?
Thank you very much, the organizers, and thank you very much, Dr. Byamukama Onesmus. This is Dr. Waswa Muganwa in Mbarara. Thank you for the presentation and the great enlightenment. I just have a question. Professor from Cuba, Professor Yarini, developed an algorithm to try to predict hypertension after preeclampsia. I don't know, have you had any experience with this algorithm? I think it's something to do with the features and the laboratory factors that are tested. I don't know, have you had a chance to use this algorithm? Thank you.
Thank you, Dr. Waswa. Yes, I'm aware Professor Yarini developed an algorithm. It has just skipped my mind, but I will look it up and I will provide the information to you.
Are there any other questions? I know that you can either add it to the Q&A box, or if any of the other panelists have any questions for Onesmus.
I have a question.
Yep. Sure.
What do you think we can say? Oh, sorry. You really beautifully highlighted the importance of postpartum follow-up in order to detect which women are going on to develop these complications.
Yeah.
Do you have any thoughts or ideas about what we could actually do in terms of interventions to try and actually reduce the future risk for these women? And have you had any experience of that in your setting? I know it's a hard question.
Yeah, thank you very much for that question. So interventions for us to be able to prevent. So number one, we need to do the screening during antenatal care, get those that do have hypertension, preeclampsia, and start treatment very early. I think in sub-Saharan Africa and most of the low middle income countries, the screening and detection of preeclampsia is very low. So most women come late when they already have end organ damage. And so that increases their further risk of the cardiovascular renal risk. So I do believe early screening for them, and initiating treatment would be very key. Yeah, but then also some of the things that I talked about for those that already have preeclampsia, it's key that we leverage these maternal health clinics, community platforms to do the follow-up, because the biggest challenge that we have is lost follow-up for them. A woman is last seen at delivery, very few come back for follow-up, even at 6 weeks, which should be standard. And beyond 6 weeks, it's very difficult to, have women come back for follow-up. So having a structured follow-up and, integrating it into the primary healthcare systems, maternal child healthcare clinics would be a key thing. Yeah. Thank you for that question.
Thank you so much. So we are right on time to move on to our next talk, and very honoured to introduce Dr. Alice Beardmore-Gray, who is a clinical lecturer and a registrar in Obs and Gynae at King's College. She is currently supported by the King's Health Partner Centre for Translational Medicine as a postdoctoral clinical research fellowship. And she's leading the Empowered study, which basically aims to understand how to improve postnatal care and follow-up for women, which is very relevant to what we've been hearing about. Her PhD was the Cradle 4 trial, which evaluated optimal timing of birth for women with late preterm preeclampsia, and she's going to be discussing that topic a little bit more today. So I will hand the floor over to you, Alice, if you want to sit there. So Abby is controlling the slides.
Okay,
if that's
okay. Yeah, that's okay. Yeah, thank you so much, everyone. It's a real pleasure to be here, and thank you, Erasmus, for a really, really brilliant talk, and I think highlighting a really key point that preeclampsia does not end with delivery, and that's something we will need to be really, really mindful of. That said, I'm going to take you back to the point of delivery and ask the question of when is the best time to offer birth for women who have pregnancies with high blood pressure. And these are our findings from a Cochrane review, which was published yesterday. So thank you for joining today. You should be hopefully among the first people to hear these findings, and please share them widely with your networks. And this is on behalf of our team, who you can see listed below. Yeah, perfect. So the question, and I've only got, I think, 10 minutes, so I'm going to keep it to the headline findings, and hopefully that will pique your interest enough to go and read the full review, and I'll provide a link to that at the end. So the question that we set out to answer is early birth safer for mum and for baby in pregnancies affected by high blood pressure? We know that hypertensive disorders of pregnancy are significant contributors to maternal and perinatal morbidity and mortality. And we know that planned early birth is currently the only definitive management option that we have available. The alternative is close monitoring, so expectant management, so long as there are no severe complications. And deciding at what point planned early birth should be offered is really the kind of clinical decision that we grapple with day in, day out, and I'm sure many of you online will relate to that. It's clear that before 34 weeks, which is a really, really important milestone for fetal lung development, and in particular, that careful monitoring is preferable unless there are serious complications. Beyond 34 weeks, the evidence is a lot less certain, and it depends on the presence or absence of severe features, of course, most importantly, the woman's preferences, and also the type of hypertensive disorder. So hypertensive disorders of pregnancy obviously encompass chronic hypertension, gestational hypertension, and preeclampsia, which, as we know, is the most severe. And the recommendations currently around timing of birth for those different conditions varies, with 37 weeks currently recommended for women who have preeclampsia, whereas women who have gestational hypertension or chronic hypertension may be able to continue the pregnancy up to 39 or 40 weeks. In this review, we looked at all hypertensive disorders together, but again, when you look at the results in more detail, you see that we did a subgroup analysis to try and stratify the results according to the type of hypertensive disorder as well. Both options have risks and benefits, and what we wanted to do was to establish the safest option. And just to point out that this was an updated review. So Prof. Kath Kluver, who's the senior author on this updated review, published the first version in 2017. And since that time, 2 additional trials have been published, which involved a far greater number of women, importantly with pre-eclampsia, and also 1 trial which was conducted in low and middle income countries. So we felt that it was important to update the review in order to incorporate this new evidence. Next slide, please. So what did we do? We followed Cochrane standards, and we had an information specialist, Charlene Bridges, who we're very grateful to, who searched the databases that you can see listed there. We looked at studies published between the end date of the previous review up until the 16th of January this year with no language restrictions. And we sought to include any randomized control trials comparing planned early birth with expectant management for women with hypertensive disorders of pregnancy from 34 weeks gestation onwards. We used the Cochrane Risk of Bias 2 tool to assess the trials and the included studies, as well as the Cochrane Trustworthiness tool. And we then proceeded to a long process of data extraction and synthesis. So 2 review authors independently extracting data and then conducting statistical analysis in RevMan and assessing the certainty of evidence using GRADE. So the key outcomes that we set out to evaluate, so we had our pre-specified critical outcomes, which as you can see there included a composite outcome of maternal mortality and morbidity, as well as a composite outcome of perinatal mortality and morbidity, as well as then maternal death, fetal death and neonatal death. And then you can see on the right, we also evaluated our pre-specified important outcomes, as well as additional short-term maternal and perinatal outcomes, which are not listed here, but again, you can read in the full publication, as well as maternal quality of life and health resource use measures. And just to say, I think this is an element of the updated review that we're really, really proud of, and actually collaborated very closely with Action on Pre-eclampsia with, which was to make sure that the design of the review, as far as possible, incorporated outcomes that were important to women who have lived experience of hypertensive disorders, and particularly pre-eclampsia. So we invited participants through initially an online survey and then subsequent virtual interviews. And you can see at the bottom here, one of the most impactful conversations that I had during this process, highlighting one woman's perspective on earlier birth and what that might have meant for her. And we're incredibly grateful to all of the women who really kindly took the time to participate. It's really, really important. And what they told us was the importance of including things such as future health risks, which again we've just heard about, as well as mental health, birth trauma, breastfeeding, longer term infant development, and really how we can improve our process of shared decision making around future pregnancies. And I think sadly this is something which we weren't actually able to fully report on, simply because most included studies don't include many of these things. So I think that's also my call to action to all of you guys out there who are currently conducting studies, and for ourselves, to make sure that we really make sure we're collecting these outcomes in the future. So what did we find? We included 6 randomized controlled trials, all comparing planned early birth versus expectant management. All studies were assessed as being at low risk in terms of trustworthiness, and 5 out of 6 at low risk of bias. And this comprised a total of 3,491 women with hypertensive disorders. And again, you can see the different study characteristics on the right there. So the split between high income and low income settings, as well as the type of hypertensive disorder, and the specific gestational window for delivery that each study evaluated, which largely corresponded to the type of hypertensive disorder that was being evaluated. And these, as I say, are just our headline results from the summary of findings table. But essentially, we found with high certainty that planned early birth significantly reduced a woman's risk of maternal mortality and morbidity events, with, again, high certainty evidence that there was no subsequent increased risk in cesarean section, which is obviously, again, a really, really important outcome for both clinicians and women when we're thinking about the trade-offs involved in this decision. We found that there was a significant reduction in fetal death, but the certainty around this was moderate because it came primarily from one trial. Again, very reassuringly, but with moderate certainty, we found no significant increase in admission to the neonatal unit. In terms of looking at maternal death and neonatal death, these outcomes were much, much rarer, and that meant that obviously we had much lower certainty in terms of the conclusions that we were able to draw. What does this all mean? So our findings show high certainty evidence that serious maternal complications are nearly halved in women who have a planned early birth compared to those managed with watchful waiting, with no increased risk of cesarean section. And you can just see there below the forest plot highlighting our maternal composite outcome. For the baby, we found that planned early birth likely results in a large reduction in the risk of stillbirth and likely no difference in the risk of neonatal unit admission. And again, you can see the forest plot there for fetal death. In terms of our subgroup analyses, we looked at whether there were significant differences between high and low income settings, and actually, really importantly, the maternal benefit held across different income settings. So what that goes to show is that even in settings where women are receiving appropriate care and monitoring, there is still a benefit to earlier delivery. There was no significant differences between studies, including women with preeclampsia only, but again, important to take into consideration that obviously women who have gestational hypertension or chronic hypertension will likely opt for a later delivery, and that's appropriate. And again, no significant differences between studies with different mean gestational ages at randomization, which again, I think is very, very reassuring. In terms of what we now do with this evidence, for women with preeclampsia in particular, the evidence supports planned early birth from 34 weeks and certainly no later than 37 weeks. Overall, these findings give both clinicians and women much clearer information about timing of birth. And I think what's really important is to take these findings back to your teams, back to where you work, and sit down and have open conversations with the women that you're looking after about what the risks and benefits are, supported by what is now, I believe, good quality evidence. And then again, as we've already heard, we still need a lot more information about the longer term outcomes, both for the baby and for the mum. And that is everything for now. So thank you very, very much for listening. Happy to take any questions. And there's a QR code there, which you can scan, and that will take you to the full paper.
Thank you so much, Alice. That was really, really interesting and very exciting that we are the first people seeing your findings. So thank you for sharing. And clearly everyone agrees with you because we've got lots of questions. So maybe you can answer one or two of these questions before we move on. You can take your pick. So if a woman has normal preeclampsia ratio with blood pressure well controlled on low dose single antihypertensive, no fetal growth concern, but urine PCR is 32, she's a primate, would you still induce her at 37 weeks?
Yes, I absolutely would. I think we've got really clear evidence that preeclampsia is progressive, it's unpredictable. You don't gain any benefit by waiting at that stage. And actually, if you look at the individual trials, so particularly the Phoenix trial and the Cradle 4 trial, which were included in this Cochrane review, we see that beyond well, even 34 weeks, but certainly 37 weeks, women who are delivered later are more likely to have an SGA baby and are more likely to end up with an emergency C-section. And in the very worst case scenario, possibly a stillbirth. So yeah, I would absolutely still induce her at 37 weeks.
I think maybe you can quickly answer all these questions, actually. Can we have some advice about managing women with a borderline raised urine PCR?
I mean, I guess that's tricky, isn't it? Because I think, you need to be confident in your diagnosis. And that's where, if you're working in a setting where you have access to biomarkers and PLGF testing, I think you need to be clear on your diagnosis. And so in that situation, I think I'd want more clinical information about the woman's blood pressure, her creatinine, the rest of her biochemistry, and ideally a PLGF if you have it, as well as the growth of the baby. So yeah, more information.
The next question, I think you touched upon, but if you can clarify, did you use trial data from both low, middle, and high income countries? And if so, can these findings be applied across all healthcare systems, given huge differences and confounders?
Yeah, it's a good question, and I think I did touch on it briefly, and there's a lot more information in the subgroup analyses, which sadly I don't have time to go into today. So 5 of the trials were conducted in high income settings. In the previous review published in 2017, they were all high income settings. So I think it was a strength of this updated review that we were able to include one trial that was conducted in low and middle income countries. And certainly, I think, as I mentioned, the maternal benefit is clear that holds across all income settings. I think in terms of the infant outcomes, so for example, if you look at the large reduction in stillbirth, that came from the trial, which was conducted in low and middle income countries. Nevertheless, we didn't actually, when we did the subgroup analysis, there wasn't actually a significant difference in the perinatal composite between income settings. So I would suggest that these are still generalizable across all settings.
And just one final question, is there work within this review looking exclusively at preeclampsia and not combining preeclampsia with other hypertensive disorders?
Yes. Yeah, and I'm glad. So again, I'm gonna say please read the review and please look at the subgroup analyses. We started this piece of work in 2023, so it's taken a long time. But yeah, absolutely. And I think it's really important that although the review as a whole looked at women with any type of hypertensive disorder after 34 weeks, clearly there are differences, and clearly it's not appropriate to group them all together. So for women who have preeclampsia, I think delivery from 34 weeks is really, really important to consider and have that conversation. I think for women who have gestational hypertension or chronic hypertension, and the trials that were included, who included those women, their gestational windows for timing of delivery were much different, and they generally started around either 36 or 38 weeks and went up to sort of 39 or 40. So yeah, absolutely, it's important to tease out the different types, and you can do that in subgroup analyses. But overall, again, no significant differences in those subgroups, which I think is reassuring. So even if you did have a woman with chronic hypertension who you're worried about, I think the evidence would still support an earlier birth.
Thank you so much, Alice. I think we will all go and read the article after this webinar. And just moving on, really pleased to have Dr. Catherine Clark with us, who is a midwife and academic researcher at King's. Her PhD, which she completed a few years ago, was on the prediction and diagnosis of pregnancy-associated acute kidney injury, and she continues to work with an international network of nurses and midwives to advocate for improved understanding of kidney injury in pregnancy. She's the founder and co-lead of the Global Pre-eclampsia Consortium, which she's going to tell you a little bit more about now.
Super. Thank you so much, Anna, and thank you, Prof. Shannon, and everyone at APEC for the opportunity to speak today. So that was a really kind introduction. So indeed, we've heard a bit about how preeclampsia is associated with kidney disease, and so I'm just going to share a bit about the work that we're doing in that space. If I can move the slides on, there we go. So when women experience an acute kidney injury, that's where they have a sudden deterioration in their kidney function, and preeclampsia globally is one of the most common causes for pregnancy-associated AKI or PRACI. These are some quotes from women who experienced it. I would pray sometimes to God to take my life, but my children are too young. I didn't know what was happening. I thought I was going to die. They told me it was too late. Why didn't they see it earlier? And I think this resonates to a lot of the conversations we've been having so far. Pregnancy AKI is a big problem, and it is a global problem. It is over 30 times more common in low and middle income settings, but and in those settings, 1 in 10 mothers will die and 1 in 3 of their babies will die. So it's associated with really poor outcomes. But globally, it affects 3 to 4% of pregnancies, and those numbers are rising. So it's not, it's everybody's problem. And it's also, as we've heard earlier, what happens in pregnancy isn't the end. People who have a pregnancy AKI, specifically, whatever the cause of that prachi, have increased risk of peripheral vascular disease, 22-fold increased risk of heart failure, and 23-fold increased risk of stroke. And it's even something we should think about for women who've had AKI prior to pregnancy, that their risk of preeclampsia is much higher in this pregnancy. And also, if you've had a preeclampsia with a prachi in a current pregnancy, your risk is again higher in a future pregnancy. The worse the preeclampsia, the more likely you are to have an AKI. So it really isn't a standalone problem and is very much intertwined with the picture of preeclampsia and eclampsia. These are some data from a study that was done by Dr. Katie Kurt as part of her PhD in Sierra Leone, and this shows us that preeclampsia in Sierra Leone was the most common cause for AKI. And you can see from that graph on the bottom right-hand side that those with AKI did much worse all across the board. So all the bad things were more likely to happen to them if they had an acute kidney injury. So we can't ignore it. And that's why we set up the Global Prachi Consortium. And we're bringing together a network of people to use research and education to try and address specifically these kidney problems. So we started last year and we did a big survey looking at what the problems were, led by a midwife from Indonesia. We then had our launch event, which we've written about, so please feel free to have a look. And then we came up with 4 things that we wanted to do. We came up with some focused ideas for research. We've started to develop a clinical toolkit. We've developed a Kidney Kind Champions program and an education setup. And we've also developing a pathway of care for the prevention and management of pregnancy AKI. But the thing I'd like to talk to you a little bit in the last couple of minutes is about this global snapshot, which we are in the process of launching at the moment, and really we need everybody's help with. The reason we're doing a global snapshot is because there's been a few big meetings, one done by KDIGO, one done by ADKI, names that don't matter, but big meetings that have confirmed we need to be able to define the scale of the problem. Because if we don't know how common prachi is globally, we can't get money, we can't lobby policymakers, and we can't change systems. The International Society of Nephrology did a snapshot on AKI outside pregnancy, and it worked really well. So our aim is to copy that. And now the time is right for a whole heap of different reasons. And so what we just need is your help. What we mean by a snapshot is a global service evaluation. It's an audit, it's not research. Copying what the ISN did before, we're confident that we shouldn't need much in way of ethics approvals. And we have very high level data collection, so limited effort from those who are submitting cases. We're asking sites to register their interest, and we've extended the deadline to the middle of June. And we will then work with sites up till September to prepare for data collection. And then each site will choose a 4-week window to collect data. And what that will look like is that at your site, you would choose your 4-week window. For the first 3 weeks, any woman presenting with prachi would enter the snapshot, and you would record this high-level anonymized data about her. You would then either at 7 days post her admission to the cohort, or at the point she is discharged, or sadly at the point she dies, we would record some follow-up. That final week of data collection is just for those follow-up. We've got a very loose definition of suspected AKI to make sure that this will work in settings where laboratory access is not possible. So the sites that this is open to is literally anywhere in the world that provides care to women who are pregnant and or women with acute kidney injury. So health posts and community settings, district hospitals, tertiary hospitals, high and low income. You don't need to have intensive care. You don't need to have a nephrologist. So what I would ask is any midwives, obstetricians, nephrologists on the call, please join this piece of work. This is the QR code to register your interest. There is no obligation. Please reach out and we'd be very happy to share more information. Whistle stop tour, but thank you so much for the opportunity to speak.
Thank you so much, Catherine. We have 1 or 2 minutes for questions if anyone does have any questions or clarifications. So we do have one question. How can we reduce the women experiencing AKI in the first place? Is it preventable? How do we manage PrACI to reduce the mortality for these women?
Yeah, absolutely. And prevention is where we're focusing most of our efforts, because we really believe that the vast majority of PrACI, from our review of the evidence, from case studies, from talking to very experienced clinicians, the vast majority of PrACIs are avoidable. And the best way to avoid them is through good antenatal care, early use of aspirin in the right women, prevention of pre-eclampsia, good management of hypertension, good management in the cases of hemorrhage and infection. But specifically to AKI, it's about the fluid management during those episodes. So using our very basic clinical skills, upskilling our midwives, enabling our midwives to do very good fluid balance. So we notice when someone's urine output is decreasing, or indeed their fluid balances, so that we can use very targeted and individualized fluid management to protect those kidneys, and then also make choices about medication, so avoiding those nephrotoxic non-steroidals, not giving the whopping dose of diclofenac post delivery. So it's about these small tweaks actually that will improve outcomes. And then the management is very much about where you are and what's available to you. But certainly I would suggest everyone goes and has a look at our website, praci.org, where there's a lot of information about this, and we're going to be uploading some exciting bits to our clinical toolkit, which hopefully will answer some of that in a bit more detail.
Amazing, thank you. And what we will do is share the QR code and share the link after the webinar as well with everyone who's registered. So if you missed, if you haven't had a chance to take a photo of the slides, we will share them with you if you're interested to get involved. Thank you, Catherine. So just moving on the theme of taking action and being involved in preeclampsia education, reducing the risk of preeclampsia, I'm just going to share the APEC-UK website just to show you some new resources that we have added. So again, we'll be sharing the link for this, but what we have done working closely with APEC-UK is had a number of specialists who work in preeclampsia create slide decks that can be used for educational purposes for healthcare professionals, for example, doctors, midwives, and also to kind of educate them on preeclampsia. So we have a few different slide decks about different topics, for example, how to identify preeclampsia, who should you be screening, how should you be screening them, and these are already created. All you have to do is put people together in a room from your hospitals and teach them about it. So you just have to fill this form to tell us that you'll be using the slides, and once you fill this form you'll have access to, at the moment I think there's 3 slide decks, and all we ask for in return is to send us some photos of you doing this educational activity in your own hospitals and centres, so we can share it within our community, so we can share it within our website. There's so many resources out there that are already available, done by experts. So there's no point us doing the work twice. So we really want to make it easy for us to educate everyone on preeclampsia. So we'll be again sharing the link for this part of the website if you're interested in running your own study day event using some of our slides. And next, I'm going to invite, let me stop sharing. Perfect. So next, I'm going to invite Dr. Chileshi to come and speak. So she is a doctor from Zambia and also just about to finish her PhD looking at prediction of preeclampsia using point of care PLGF. But she's also doing some amazing work in empowering all of our early career research work and capacity building within global health research. So she's going to speak a little bit about opportunities to get involved if you're an early career researcher.
Thank you so much for that kind of introduction. Good.
You're cutting off a little bit, Chileshi.
Sorry, can you hear me?
That's much better.
Okay. I will speak up. I'm so sorry. I've got a frog in my throat. So I will just do my best and just remember how to share the screen and hopefully that is working. And can you confirm that I am presenting?
Yeah.
Okay, brilliant. Thank you so much, everybody, and thank you to all the speakers before me. It's really inspiring to hear what everybody has been doing. It's really inspiring to be a part of the team. I'm Chileshi Mobulawale. I'm as Anna said, PhD fellow, PhD student research fellow at King's College London, working with the CRIBS group on improving preeclampsia management and obstetric health management in resource-constrained settings. So one of the things that is in the very DNA of CRIBS is capacity strengthening, is making sure that anything that's done is done with the support and with the inclusion of local researchers, local students, local people who are keen on research, and increasing their ability to participate and contribute in meaningful ways. And so one of the things that is being done to concretize, to cement this further, is to try and introduce some more formal ways that we are offering the capacity strengthening to our various fellows and to other people who may be interested in working with us. The G's, oh, right, okay. Oh dear, it's having some trouble. Okay. So introducing the CRIBS Academy, which is very much part of the CRIBS model, which is to learn by doing. And so it's got three main arms: practical training. So people who join us will participate very actively in all the research studies that we're conducting in various parts of the world, participating in designing studies, delivering them, reporting on them, and disseminating the information at various levels in research meetings and in the community. A big part of how we do this is providing resources. So I will talk a little bit in the next slide about the seminal program that Dr. Alex Ridout designed and developed, which is the seed funding program. And it was essentially small grants that were designed to help people develop a research idea, all the way from the conception of it through actually conducting a little research study with support, with advice and mentorship, and then being able to present it at various fora, whether that's local meetings, international meetings, and in our annual meetings as CRIBS. The other aspect of it is the dual mentorship. So we have a lot of powerhouses of pre-eclampsia and obstetric health research, and all of our mentees and all of the people who have the opportunity to work with us very much benefit from that mentorship. And also coupling that with mentorship from local professors, local clinicians, and local researchers in those settings. I myself am a beneficiary of this model, and it works really, really well, as you'll see. So these are some of the people who've worked with us. The seed funding program started. It was a notice was put out to submit ideas for research, for a little research project. and people submitted their applications either individually or as groups, and the 8 best ideas were picked. And then over the course of several months, over a year, all of the people who were selected as seed funders were then supported through developing their ideas, as I mentioned previously. Various members of this capacity building consortium have gone on to really amazing things, to studying at Oxford, to joining, to continuing their research development as PhD students, so joining in a formal research capacity, this CRIBS consortium, and or even those who have left have gone on to continue research. So I've had the privilege of mentoring some young, keen students who are not currently part of CRIBS, but continue to check in, continue to say, oh, I'm where I am, I'm doing research. And so planting those seeds and nurturing them really, really goes a long way. And so to talk a little bit more about the project, you can see that there were different teams and different team sizes. They've learned a lot about presenting, they've gained a lot of confidence, and continue to take this forward both locally and internationally. Some of the feedback from our seed funders: I want to solve problems. I've learned how to approach and reassure participants. This is my first research to be published, and that's such a key and critical niche. And I'll talk a little bit about that when I talk more about the partnerships that we've set up with some of the other research capacity strengthening efforts in other research groups. Just to share one or two more, it makes us proud to contribute solving problems in our country, which is such an important part of research. Nothing about us without us. So I'm very, very pleased with the problem I have now, which is that I'm running out of space. I have to make the pictures smaller and smaller to fit all of our current PhD students and research fellows. Magenda's actually just graduated. So there's lots and lots of people who are not in this picture, who are recently graduating and now advancing to even more senior roles. But if you can, oh, sorry about that. Just to shout out Moses in the corner, you might have noticed him in this previous picture in the bottom right here. So started out as one of the people who was a seed funder, is now one of our PhD students, and will very soon be one of our research leaders, as is the case for all of the people in this picture. As I said, with CRIBS, because it's such a core part of the identity of this group, everybody who's a part of this group is really committed to capacity strengthening, to building other people up, to carrying people along with them. And it really shows in the work that we do and in the research that we deliver. So I don't have a lot of time, so I'm just going to talk very briefly about two of the initiatives that are currently ongoing. So one of them is the peer-to-peer mentorship. So the screen grab on the left shows a recent meeting that we had. Several of our PhD students checked in, and in this current age of AI and how to use it and whether to use it in research and how best to use it in research, we are very, very keen not to be left behind, and also to make sure that everybody is leveraging it well and in ethical ways. And so Anna was very instrumental in organizing some training in the ethical use of AI for rapid systematic reviews. So there's all kinds of information on the internet, lots and lots of really strong evidence-based studies. And this is another tool in closing the evidence to action gap. So this was a meeting that we held recently, just PhD students talking about how we've been using the AI, talking about how we can use it more efficiently, talking about if you are interested in trying to do a systematic review this way, how you might get started. And in the coming months, we're actually going to formalize this further. And Professor James Galloway, who has been a pioneer in this sort of rapid AI-supported systematic review, is going to offer training to our Sierra Leone and Zambia fellows and other research-interested parties. So it's a really exciting time to be involved. On the right-hand side is a sort of high-level collaboration that we're doing. So one of our big research grants is the NIHR supported National Institutes of Health Research supported grant, right? And we've got the CRIBS, the Cradle B, Cradle Smart and B Smart grants just starting in various sites, South Africa, Zambia, Sierra Leone, India. And the Cradle B part of this is supporting a lot of capacity strengthening through the NIHR. We've been able to partner with other right recipients. So ICOR, which is focused on improving hypertension management and research in rural Africa, Smart Health Caribbean, so partnering with Imperial College, the George Institute, and the University of the West Indies. And of course, there's us at the top there. And this is very much endorsed and supported by the NIHR themselves. They've got a couple of initiatives where they try to facilitate some cross-pollination between their prize recipients, their award recipients. And so they're really, really excited to see how best they can support us and work with us. Another thing that we're doing as these three groups is developing a capacity strengthening framework. So as an example, ICOR has quite a lot of expertise and investment in developing researchers to the next stage. So once you've actually gotten your PhD, what happens in the postdoctoral stage, what happens after the postdoctoral stage on your way to independence. And ICOR is very committed to building and supporting researchers at that stage. I'm very pleased and proud to say that CRIBS is really, really addressing a niche where we are able to take research interested but not very research experienced people, whether clinicians or non-clinicians, and to help them formalize that interest and formalize that passion with methodology, with experience, whether that's experience conducting research, presenting it, and so on. So it's a really, really, again, as I said, exciting time, and there's a lot of amazing opportunities. And just a quick shout out to Dr. Catherine Clark, who presented on PrAC just previously, who is doing a lot of work with midwives to build that confidence and research capacity. Midwives are such an important part of our research delivery, of our patient engagement, and of the development of good, strong ideas. And so there's a lot of work going on to make sure that this is a really strong co-developed effort. So just the last slide to kind of discuss how we're kind of embedding all of the work we're doing in existing infrastructure and also trying to create some of the new infrastructure. I mentioned briefly the research capacity strengthening framework that we're working on with our other right partners. But there's also a lot of things that are already existing. We work with the universities. So our partnership in Sierra Leone involves the University of Sierra Leone. Our partner in Zambia involves the University of Zambia. In Cape Town, we're working with University of Cape Town, University of Stellenbosch, and the various hospitals there. We are working within government policy. We're working within WHO frameworks. So we're very much working with and believe in strengthening what exists, not working outside it or in parallel or in silos to it. Always looking for opportunities to take advantage of the policy windows and the other things that are going on to slot in what we've got going on as well. So I think that's my last slide, save one. Thank you so much. And please do get in touch if you are interested in working with us, if you're interested in sharing some of the mentorship wins and the resources that have been beneficial to you or to your students. It's something that we are very, very keen to grow. Thank you. Take.
Thank you so much, Taneshi. Beautiful slides, and you embarrassed all of us with our screenshots. And yes, so again, if you are an early career researcher, I'm sure Taneshi will love to be contacted if you want to get involved.
Absolutely.
Just moving quickly on, as I appreciate we're a little bit behind. I'm just going to hand the floor off to Dr. Miss Alfie, who is one of the PhD students from Sierra Leone, and she'll be talking to you a little bit about her PhD. So thank you, Alfie.
Thank you. Can you hear me? Excellent. Hi, everybody. My name is Alfreda Kwarmawa. I'm one of the PhD students with the Papagaya project within CRIBS Global, and I'll be sharing a bit about one component of my PhD. So to start with, I'd like to ask you a rhetorical question. And that is, who do you think decides the research agenda on hypertensive disorders and pregnancy? Is it the women who've had a lifetime experience of HDP? Or perhaps it's the healthcare providers caring for them? Maybe it's their families that have to navigate these experiences alongside them day on day on day. Or is it the researchers and funders deciding which questions are important enough to study? For a long time, particularly in low and lower middle income settings, research priorities have been shaped without directly asking people most affected. What do you want research to focus on? And that raises another important question. Does who sets the research agenda actually matter? I think it does, especially in lower and lower income contexts. We know that hypertensive disorders and pregnancy are highly prevalent across Africa and Southeast Asia. And while significant body of research does exist in this area, much of that research in this space is one, not being generated in these contexts, carrying the greatest burden, and two, rarely being informed by priority setting exercises that meaningfully include people with lived experience. So the need for a research agenda that reflects the realities and priorities of people in low-income contexts specifically becomes even more important. And that links to what I'm doing. This project builds on growing recognition that people with lived experience of HDP should have a greater role in shaping research priorities. Similar PSPs, so priority setting partnerships, have been conducted in this area, including in the UK and Ghana, and our project specifically focuses on Sierra Leone and Zambia. In partnership with the James Lind Alliance, we're implementing 2 priority setting partnerships, one in Sierra Leone and one in Zambia, to identify the unanswered research questions that matter most to the people directly affected by hypertensive disorders of pregnancy. The project brings together women with lived experience, family members, healthcare professionals, as well as policymakers to collectively identify what research should focus on moving forward. The ultimate goal is to develop a top 10 list of priorities, one for each country, and advocate for these with global funders, ensuring that the research priorities of the future are aligned to Sierra Leonean and Zambian realities. To support this process, we've done a lot of work. We've established technical working groups, one in each country, alongside an overarching steering group to support the coordination and shared learning across the 2 technical working groups. We've jointly developed and tested the consultation tools. We've secured ethical approvals, and I'm pleased to share that as of this month, our surveys in both countries are live. So if you're based in either country, if you're in Sierra Leone or Zambia, I encourage you to take the survey and to get involved. If you don't live in either of these countries, but have links to networks of people that would be interested in sharing their opinions, please do share these QR codes with them as well. The QR codes on the screen will take you directly to the surveys, and additional project information can be found on the websites linked below the posters. And the response so far has actually been really encouraging. We've received over 200 research questions and uncertainties from Sierra Leone and about 70 from Zambia, despite the fact that the Zambian survey only launched this Tuesday. So I will end with the principle that sits behind this entire project and our project slogan: my voice, your voice, our voice. As Chileshi said, across the Cribs Global Group, there's a strong commitment to the idea that research should be shaped by people with lived experience. This priority setting partnership is one way we're trying to amplify the voices of people living these realities and ensure that they have a greater role in shaping the questions research seeks to answer. And then, wait. And that's a little video that I took while doing data collection a couple of days ago. Oh, not again. Okay, thank you so much for listening. Thank you for having me also. Take care, everybody.
Thank you so much, Alfie. And yeah, I cannot agree more. I think this is the most important part of everything that we're doing and everything that we're talking about. And it flows very nicely into our final part of the day, which is really listening, hearing from the women themselves, from the communities themselves. So I'm just going to hand over to Bucky, who'll introduce herself and introduce our amazing panel. Over to you, Bucky. Thank you.
Thank you so much. Can you hear me okay? Good. All right. Amazing. Good afternoon, everyone. Thank you all so much for joining. We are going to go on to an important segment of today. So my name is Bucky Oladokan. I'm a midwife and a health visitor. Also been working with the team on pre-eclampsia, not just in the UK, but across the world. And something very close to my heart recently is also Nigeria as well. We're looking at maternal mortality in Nigeria too. So today's panel will bring together lived experiences, frontline carers, research and community perspectives on pre-eclampsia. The voice of pre-eclampsia survivors must always be our why. We have to always remember why we're doing this. And we must keep them at the center of our hearts, because it is the reason why we continue to push the boundaries on research and fight for better pathways and care globally. So hoping you all know by now, but just to give you a summary, the Cradle device is an accurate, portable, low-cost blood pressure pulse and shock index monitor designed to help healthcare workers identify women at risk of complications such as preeclampsia and shock during their pregnancy, childbirth, and postnatal period. Just want to start off with a little trigger warning, because we will be talking about I think sensitive subjects and things might come up that could trigger. So we just want to say that, we will have panel, we'll have professionals and also personal experiences related to preeclampsia, as well as its impact on the mothers, families, and communities that have been affected. And that might include complications, trauma, and loss. We know that these are emotionally deep, so we do ask that you take care of yourself and step away at any time if it is needed. So I will start off with one of our amazing lived experience they're coming from their lived experience as a preeclampsia survivor. So do we have Mariam here with us?
I'm here.
Oh, hello. Hi, Mariam. Thank you so much for joining us. So I just have an initial question for you. I'll ask you to please introduce yourself, and then I will give you your question afterwards. So please let us know all about you.
Okay, so my name is Miriam Chalwe. I'm from Zambia. I've had preeclampsia twice. I'm a mother of 3, and the firstborns are twins. The preeclampsia was severe then, and this 6-month-old the preeclampsia was better. I don't know if you can say that. Yes, so
amazing. Thank you so much for introducing yourself. I actually saw your plaque on the Cribs global campaign, asking you to send a message to healthcare and research professionals. And yours read, "I want to know if I can ever have a pre-eclampsia-free pregnancy after surviving it." It said twice, but it sounds like you've had it 3 times. So I really reflected on your question and the strong sense of hope that it carries. How did your experiences of preeclampsia in Zambia shape the question that you asked?
So my question was, because the first pregnancy that I had no idea about preeclampsia, and it felt like even where I was going for the antenatal checkup, they would just say, "No, you have high blood pressure and your legs are swelling," because my legs used to swell so badly. My legs would swell, my face would swell, my hands would swell, everything, even my tummy area, to the point where they could not hear the baby's heartbeat. So it was very difficult for me because I didn't know what was happening and I wasn't told what was happening.
So how do you feel that kind of informed the question in terms of the hope that something will change in the future?
I hope that in the future, there'll be a system where preeclampsia is detected as early as possible, and mostly for us here in Zambia, it's not that widely known by mothers, especially in some areas. They wouldn't even know. So I hope that the word can be taken to them so that they know earlier. Even they can have some classes done, and just so that they know the symptoms and what is going on with their bodies, especially when they're pregnant.
Amazing. Thank you so much. I think you've just captured the reason why we're here and why we continue to come back every year, and why all the amazing work is being done in the community, raise awareness, both, for mothers as well as for professionals and for researchers as well. Everything we've heard today is just about how we detect early, and how we prevent and how we save lives. So thank you so much, Maureen, for answering those questions for us. Thank you so much. I'm going to go over to Abby now, and ask you also to introduce yourself, and then I'll also ask you a question.
Hiya.
Hello.
So I'm Abby. I had severe early onset preeclampsia in my first pregnancy, which meant that I had to have a very premature delivery at 24 weeks and 5 days. My baby son, Jude, he survived for 32 days and then he passed away in neonatal care due to being so severely premature.
Thank you. I'm so sorry to hear about this. I wanted to ask, actually, out of your lived experience of preeclampsia in the UK, and how that motivated you to advocate and raise awareness about early identification, care pathways, and the impact of this condition.
I think that it caused me to want to raise awareness just due to my initial lack of understanding the signs and symptoms of preeclampsia. So it was my first pregnancy. I hadn't really heard of preeclampsia, but as soon as I started swelling up, I think I did some research around being swollen and then came across preeclampsia. But my experience then was if I spoke to friends who had been pregnant or knew of people who had been pregnant, they would say, oh, such and such had that at 37 weeks, everything was fine. I didn't understand the seriousness of the condition having it so early, and I didn't believe that it could happen so early. So I think I want to raise awareness around the fact that, yes, lots of the time, thankfully, it is something that happens further down the line. And therefore, obviously, you can get the baby out and the outcomes are usually okay within the UK anyway. But the fact that it can happen from 20 weeks, I think, needs to be made more aware so that as women, we can identify those signs and symptoms at home from very early stages of pregnancy.
Yes, thank you so much. And I mean, as you said, it is just picking it up earlier and actually knowing that it can happen, and it's not necessarily always a late onset, or not just actually in pregnancy. It can actually happen, eclampsia can happen up postnatally, which I also think a lot of mothers don't know as well. And I suppose when I saw your video as well, it was talking about, the importance of picking up, the symptoms when you go for your routine check as well. So, I suppose just the importance as well of making sure that, we're encouraging mothers to book early, all of those, barriers to accessing maternity care early, and also, attending antenatal appointments, but sometimes doesn't necessarily feel like it's important or essential, but this is how we get to really, identify, preeclampsia early. So thank you so much. And thank you for all the work that you're doing.
Thank you. Yeah, I was just going to mention that I do think it is so important that we attend those appointments because lots of women don't have any symptoms at all or any signs essentially. And all I had, like I said, was a bit of swelling, which could have been put down as a normal pregnancy symptom and a headache. So, if I hadn't have got those checked and didn't have the blood pressure check and the urine check, that could have gone unnoticed, and then that could have been a tragic ending for myself as well as my son. So it's so important to attend those appointments.
Thank you so much, Lovely. Thank Thank you very much. Again, the reason why we're here, and the reason why we have to make sure that we are we're identifying those barriers first of all, because there are loads of barriers sometimes that we don't always know. And it's the reason why when we do have, mothers who book late from, specific communities or that have, social complexities, we really do need to understand the reason why. For me, it's never been enough just to say someone DNA'd or did not attend an appointment. You have to understand why and accommodate. We're maternity services, we should be accommodating. So actually, if it means they need to bring their child along, if it means we need to work more with, our community partners to make sure that, mothers actually understand or communities understand, that things have changed in the UK, that mothers don't necessarily need to go to their GPs anymore. They can go straight to the maternity unit. And just the way the pathway works, that will allow us to start to overcome some of these barriers to access. So it's always been that, early assessment, early risk assessment, and all of those, other things that we do routinely that help us to identify this. So I think, what Abby said is very, very crucial to communities that we work with in the UK. So I'm going to go over to talk to our healthcare professionals and people who are doing this work day in and day out and working tirelessly on the ground to improve lives for mothers with preeclampsia. So I'm going to go to Sister Betty Sam first and just ask you to introduce yourself, and then I will present your question to you too.
Hello, everyone. Thank you very much. My name is Betty Sam. I'm a retired midwife. They normally tell me I'm not tired. Have been working with Well-Body Partnership in collaboration with Ministry of Health, King's College London, as far back as 2019, 2020 on cradle device. And then I'm happy to be here on this call.
Thank you so much. We're so happy to have you. So my question is, you showed us the cradle device. How has that cradle device supported the transition towards respectful maternity care in Sierra Leone?
Thank you very much for that question. So the cradle device is a simple semi-automated device which has traffic light system, green, yellow, and red to show the condition of the woman when they come. It also has an arrow position. When the arrow is up, the blood pressure is up. When the arrow is down, the blood pressure is down. So before now, we had other traditional blood pressure machines that they used. For example, that didn't have these features. But the cradle has this singular feature, and it helps the midwives or healthcare providers to be able to look at these features and then immediately recognize that the woman is well or not well. And if the blood pressure is up, they now start to investigate why the blood pressure is up, whether it is preeclampsia. So they will do urine testing. They will also engage the woman and ask her questions about some of the symptoms, for example, headache, which have been mentioned by other presenters, And at the end, if the woman is just, let's call it mild preeclampsia, the preeclampsia is just beginning, it hasn't got to severe stage, they will tell from the landmarks whether it is in yellow or red. And all those investigations will be done to be able to early detection and also smart action to prevent preeclampsia progressing to a dangerous complication.
Thank you so much.
And it also helps to do referral,
referral pathway. Makes it easier for people to know at what point they need to intervene.
Yes.
And I loved hearing if anyone hasn't seen the song yet online, it's amazing. That was my selling point. I was selling it to everybody. So yeah.
We use that song after teaching, for example, for 2 days. It's like a take-home message.
Mm-hmm.
And anybody can understand when arrow is up, pressure is up, arrow is and all need to take action. So it's a take-home message.
Yes, it's catchy and it will stay with you. Songs always stay with us. We remember nursery rhymes, so so why not? Yes, thank you so much. Thank you for all the work that you do on the ground,
Thank you.
in preventing
A pleasure.
yes, thank you so much. Thank you. So I will go over to our last panel member, Candice, and just ask you to please introduce yourself.
Hi, good afternoon. I'm Candice. I'm an obstetrics registrar in London, in the UK. I'm also a researcher working in Sierra Leone, and I'm looking at trying to understand whether there are any differences between teenagers and adults who have preeclampsia. I'm also Sierra Leonean, so it's been great being home.
Amazing. Thank you so much. Yes, I just wanted to ask you, just with regards to the work that you do, if you could please highlight 3 things that have emerged from your experiences supporting mothers with preeclampsia, and how they differ culturally between Sierra Leone and the UK.
Yeah, absolutely. But first, I just wanted to say thank you so much to our panelists with lived experience. It's been so humbling listening to their story. So thank you so much. And I guess some of my observations really hark back to them because it's all about the patients. Having been in the really unique position to be privileged to see what healthcare is like in the UK and in Sierra Leone, though I'm not working here as a doctor necessarily, I am in clinical spaces. And one of the things that probably rings truest to me is the universality of obstetric trauma. Now, that word or that phrase in itself, it just means different things. In the UK, it's something that we recognize, that we understand, and it's like it's a known term. Whereas in Sierra Leone, if you have to say to somebody, what is obstetric trauma? How may that relate to preeclampsia? It's not something that's spoken of. And when I mean the universality of the trauma, if you were to speak to, say, some of my patients in the UK, and to speak to my patients here, the emotions that, everybody goes through at the time of whether diagnosis, whether that's feeling like your body has let you down, or you may have done something wrong, or feeling out of control, feeling that decisions are being made without you, or being separated from your baby, they all hold true, but the way in which they're expressed are so very different. And I think that has a lot to do with the differences in like the social and debrief infrastructure that exists in the 2 countries. So I know in the UK, they're going to be, we have established pathways, but I'm also very aware that many women don't necessarily have access to them in the UK, but we do have established structures for debrief. So after difficult delivery or difficult pregnancy, especially in the case of preeclampsia, there are often times you're going to have a debrief with your medical team, and they're going to say, this is what happened, and this is what we did, it's not your fault, this is what it means for the future. If you've had a bereavement, there are bereavement pathways that exist, and there's counselling and support groups that exist. In Sierra Leone, it's so very different. And those structures don't exist. When you go through something that difficult, it's usually left with your immediate, like, familial and social environment to sort of prop you up. But sometimes that's not enough, because we need people who understand, like, the process of grief, the process of debriefing at trauma, and it has to be culturally sensitive for it to be of any use. And we also, on the surface, to me, it always looks like Sierra Leonean women are the most resilient in the world, because when our ladies who've gone through the worst thing come back to see us, it's usually a spirit of, hey, it's great to see everybody, and everybody's laughing in the office. But when you take them aside, those emotions are just right at the surface, because there's not been an opportunity to process them, because you haven't spoken about it, because you have your relatives that are telling you, be strong, and it's tough, but you'll survive, you'll live, it's okay. And you have the financial pressures where you have to, okay, so there's no baby, you need to get back to work, you have to go back to the market, you have to go back to the office to start working. And Yeah, and again, I know that the system in the UK isn't perfect, but the way in which the experiences after difficult deliveries are dealt with is incredibly different. And I really, really wish that we had established structures to help women deal with their grief, because when it's just passed it over, I have no idea what the long-term emotional sequelae of that will be for our women, and especially the girls that I work with, especially the younger girls who are barely getting to grips with the fact that they're pregnant and their entire lives are going to change. And then you then have something so significant. You're stuck in hospital for a long time. You may have lost a baby and nobody told you lost your baby because they're waiting for you to be stronger to handle the news. And to be able to understand all of those realities at once is, I don't think it's usually something that your immediate family or your friends can help you deal with. Sorry, that was slightly longer.
No, yeah,
And
thank you.
I guess secondly, you've asked for three, it's a lot.
Yes, sorry. You could just get us to if it helps.
I guess it's the differences in the postnatal follow-up structure. You know, again, in the UK, we're not perfect, and patients definitely fall through the loop, and not everybody gets their post-discharge assessments. But that structure is there, and I know Alex, as a junior registrar, did a lot of work in terms of postnatal follow-up and COVID, and trying to make that remote. But in Sierra Leone, I think one of the greatest challenges I found is that that postnatal follow-up for eclamptic patients is non-existent. And so you will have somebody that's discharged from hospital, and they would have maybe bought, a week or 2 weeks worth of medication to last them. They're discharged with potentially not amazingly controlled blood pressures, and sometimes they're sent home without a clear understanding of the management pathways, or the fact that they need to continue taking their medication until they're next seen. But that's impossible because they may not have an appointment to be seen, and they don't necessarily know what's happened to them. And that's not through the fault of the healthcare system here, or the doctors or the midwives. It's just because everybody is so busy. The systems here are so overstretched. So it's so hard to be able to, speak to each patient individually and say, look, this is the issue. This is this was your blood pressure. These are your risks when you go home. You're still at risk of eclampsia. You're still at risk of stroke. You have to continue taking your medication. You have to go to your closest peripheral health unit to have your blood pressure monitored. And sadly, what happens is that once the patient is discharged, is at such a high risk here in Sierra Leone to be lost to follow-up. And when we eventually see them, because I also see my patients till about between 6 weeks and 3 months postnatally, is that a lot of them have ridiculously high blood pressures. They have, really high systolics. And then you ask them, hey, you send me your medication? They're like, no, I stopped it after a week, but I feel fine. And then you're kind of there panicking in the corner, being like, oh no, you're over the 6 weeks threshold for the hospital to see you. How do I get somebody to see you in this time? So yeah, that's probably, I think, the second one. And then finally, and I think it's one that it's a lot of what Papaya is doing, is the differences in presentation to antenatal care. And when that happens, again, the UK, we probably do slightly better than we do in Sierra Leone, but for a huge proportion of the country, most people don't present to healthcare facilities early on in the pregnancy, and that's like a significant lost opportunity to mitigate for the risk factors of, or the risk of preeclampsia. And again, that's partly to do with, health education. It's partly to do with culture, partly to do with religion. So it's such a mixed bag that's going to require a significant amount of untangling to be able to understand how we get women to healthcare early to, to mitigate the risk factors for PE.
Thank you so much. And I'm sure you have many, many more, because I can see that truly, the mothers you look after are just at the center of everything that you do. And it's so important that we take the other side, the emotional side, the social side, everything else that, envelopes women into consideration, because it really does impact on, their access to care and the relationships that we have with them as well. So everything you've kind of said about Sierra Leone, also, as we said, we're still looking at making, changes in the UK as well. And we know, that there are mothers who still slip through the net for loads of social reasons. But I also kind of always talk about, how we do have a lot of, mothers who are from Sierra Leone, who are from Zambia, Nigeria, coming over to the UK. And we do tend to find that actually, some of those challenges are present on both sides. So it's the reason why, what we're doing globally is so important. We know the things that we need to do to support, in Africa, but we must not forget the things that we need to do in the UK as well to make care more accessible, experiences better, and outcomes also better for the community and the mothers that we look after. I will hand back over to Anna now.
Thank you all so much for sharing, and you've all sent us some amazing videos as well, sharing a little bit more of your stories, which are going to be shared on our Instagram. So I urge all kind of attendees to go and have a look, because they're really, really powerful stories that everyone has shared. So I'm just going to hand back over to Professor Shannon just to close the meeting.
Yeah, thanks everybody for spending the long lunchtime with us, and it's a very exciting time, I think, in the pre-eclampsia world. Still huge amount to do, so please do be an APEC advocate. We want you to be APEC. It's not a charity without its members, and there's no formal membership. The fact that you just go and tell people to do things better makes you an APEC advocate. And please do make use of resources we have. Please do engage with everyone to try and make this problem better for the world. Stay in touch. Let's build on this momentum. Very exciting. And again, yes, keep spreading the word. We'll see you soon.
We do have some questions still that were unanswered, that weren't necessarily related to any specific talks, which maybe we can either answer via email, or we can quickly answer a few now.
We've got time. Anything pressing?
So there was one question on using ophthalmic artery pressure for predicting preeclampsia, and another question on kind of, I think this came out of the talks that we had on postnatal care, whether there's any research focusing on preconception care to limit the risk of preeclampsia.
Have we got our speakers to answer or not?
I don't think these were related to any particular talk.
Well, okay, we've got your names. We will be in touch. Yeah, these are great questions. Okay, thanks. And can I just thank the APEC team behind the scenes, Abby, Anna, and all their supporting groups. A lot goes on to make these things happen, and it's been seamless and wonderful. Just to appreciate that, and we'll keep talking. Take care, everybody.